Good afternoon and welcome to OCTalk, the show dedicated to helping home health and hospice providers keep up to date on the documentation, diagnosis coding, OASIS, and hope assessment data collection issues that matter most in home health and hospice. OCTalk aims to bring you closer to reliable experts in home health and hospice and to share the latest news and information from the industry and from the Association of Home Care Coding and Compliance. I'm Jan Milliman, Director for OC, and I'm happy to be hosting today's program. This afternoon, we're talking about querying in home health. And now I'd like to introduce our industry guests for this episode. Today, we have OC board member Sherri Parson, CEO of Infusion Health, on the call. And we also have OC advisory board member Christine Mickel, manager OASIS and coding with McBee Associates, on the call. Thanks so much for joining us today, ladies.
And thanks for having us.
Thanks, Jan.
All right, before I get started, I am going to launch a poll for us all. We're talking about queries today, and we are wondering, in your home health agency, who is responsible for querying the provider? Is it the coder, the clinician, the coding and OASIS reviewer, QA or compliance staff, or is it someone else? And if it's someone else, you can go ahead and click someone else in the poll, and then you could share who it is in the comments or in the chat or the question panes, because we'd love to get to those details. All right, I see folks are still voting on this. So I want to give it another few seconds for folks to share their thoughts on that poll question. And then we will close this poll out and we will discuss the results a little bit later in the call. All right, it looks like things have slowed down on the polling front, so I'm going to go ahead and close that and we'll discuss the results a little later. All right, and now I'm excited to get the discussion started. If you have any questions for our panelists today, listeners, please go ahead and ask them in the chat pane, and we'll try to get to as many of those questions as we can. And Sherri, I'll turn things over to you, and you can just let me know when to advance the slide.
Okay, and if I could get, oh, there we go, get slide 5. Well, thanks, Jan, and thanks for joining us as we talk about query practices. Now, I remember the first time I read AHIMA's white paper on compliant query practices. I believe we're talking way back in 2010, and I was really impressed then with the practical steps and the guidelines that were contained in this paper. And I must not have been the only one impressed, since the paper underwent many iterations until the present one, where ACDIS and AHIMA paired up, incorporating some concepts of CDI, clinical documentation improvement, to come up with the most recent beefed up version that dates at 2022. So that is still the latest and the greatest in the white paper for the compliant query process. So today we want to use this as the backdrop. This is a great resource. We want to discuss when we query, when not to query, how we query, and some of the other considerations related to querying. So first, we need to start with a definition on what a query is. And so according to AHIMA and ACDIS, a communication tool or process used to clarify documentation in the health record for documentation integrity and accuracy of diagnosis, procedures, service codes, assignment for individual encounter in any healthcare setting. And keep in mind that historically, when we have spoken about queries, that was done by healthcare personnel. But with companies beginning to leverage technology and AI, it may be auto-generated, and this is still a query, and it still needs to follow compliant practices. Next slide, please. So keep in mind that there's a lot of synonyms for a query. In healthcare personnel doing these queries, we may say clarification, we may say something like, I need to clarify the documentation, I need clinical clarification, I need to prompt the provider about X, Y, and Z, I need to alert the provider and find out this. No matter what term we use, if it meets that definition that we just shared on that previous slide, it's a query. Next slide, please. So who uses this compliant query practice? I think this was one of the realizations that really got my attention. What organizations are using this process? So first, our payers. When reviewing diagnosis, billing integrity, they are going to be taking a peek at how we arrived at specific diagnosis for reimbursement. So if they don't see the documentation, this could be troublesome for us. Do we have a query? Is it a compliant query? Did we get a response from the provider before we assigned maybe a more specific code than the information in the chart, and so forth? So you can see the implications there. This I thought was probably the second bullet, was probably the most sobering of all. Auditors use this process. So this process has been shared with the auditors. When I say auditors, I'm not talking about you and I'm talking about UPIC auditors, RAC auditors, MAC, and they'll take back money if the proper query wasn't followed potentially. These individuals, many of which that is what they're subcontracted to do, take back money. So what if we led the provider to a diagnosis because we didn't have a compliant query process? I can think of the ramifications of this particular piece, and this could be really significant. So the bottom line is we want to make sure that our organizations are following compliant query practice as lined out in this white paper is a very good template to follow. Compliance officers, of course, will be looking to see if personnel is adhering to a compliant process, what risk is it to the organization when shortcuts are taken, and how can we improve on what we do in this area? And of course, that's what compliance officers do, right? Try to get us a little bit closer to the finish line all the time and get us a little better at everything that we're doing. Revenue cycle. Are we getting compliant queries out to get the maximum reimbursement due to our organization? Of course, we can't give the provider any feedback on our reimbursement related to the query. We can't say, hey, if you pick this diagnosis, if you give me this diagnosis, I'm going to get more money. We can't refer to anything like reimbursement when we're querying. But keep in mind, sometimes the minimum that's required to bill a claim may not be what we need for compliance. And so I've seen this in my organization a couple times. Some compliance piece is skipped. Well, we didn't need that to bill. We didn't need it to bill, but we needed to be compliant. So just want to make that distinction there that sometimes there is a little bit of a difference between what we need for reimbursement and what we need for compliance. Care management. If we query the correct information, will we have a more complete picture of our patients? Of course we will. And hopefully then not only will that documentation line up, but ultimately the outcomes of our patients will be better since all that pertinent issues were addressed. So hopefully we have better outcomes as a result of that. And many on this call will fall into this last group, clinicians and healthcare professionals who need to document, assign codes, need it to be defensible, accurate, and compliant. So we need that information, but we need to be able to defend what it is that we're doing in our practice day to day. Next slide, please. So a couple key takeaways here. Now remember, and this is important, AHIMA is one of the cooperating parties of the ICD-10 CM guidelines. So when discussing this white paper, it carries some weight since, again, one of 4 organizations that make up the cooperating parties has authored this. Using the tenets of this white paper will help develop standardization across healthcare industry, and that's the entire healthcare industry, not just home health and hospice. Now, the processes listed within this paper include directives on ICD-10-CM, the procedural codes of ICD-10, and the official guidelines for coding and reporting. So you're not going to see those conflicts in there. Also taken into account is the official advice of the American Hospital Association Coding Clinic, another cooperating party. Again, realize when the coding clinic comes out, and I'm not sure we all realize this, that when we get those quarterly updates from the coding clinic, all 4 cooperating parties have to sign off on that clarification. So AHIMA's already signed off on the coding clinic that has come out before it's even come out. So again, we're not going to run into any conflicts there either. And again, it is always important to keep in the forefront of our minds that the intent of the resource is to also provide resources to external auditors for government and OIG and payer review organizations. So again, very sobering thought there when implementing anything. Next slide, please. So any kind of process within our organization, we have to make sure we get the word out. And I've seen a couple different things happen in this situation. Either an agency gets the word out to the new hires and forgets about those people that are in the rank and files and have been with the organization a while, or the opposite. They get the word out to the employees during a rollout process and they forget to add that to the orientation agenda. And then the new employees aren't aware of what's going on with something like a compliant query practice. So we want to make sure that the organization's getting the policy and training out to everyone. That's first. And not stopping there, but continuing to reevaluate what's being done, update as appropriate, and analyze where we're falling short. And of course, then we want to lead these refresher courses on the process so that as we're tweaking this, everybody has got the latest and greatest information. And even if it hasn't changed, always good to have a reminder. So make sure that any temporary help, you're maybe contracted somebody to help out with something, you've got a contracted employee, we want to make sure that they get that word as well. And we always want to keep the compliance policy handy in case it's needed for legal matters. So tracing the steps instituted by the organization and obtaining information related to patients sometimes is very helpful if we're filing some kind of legal matter or something has been filed against us. We want to be able to have that handy to show the steps we've taken to ensure the integrity of the health record. And finally, build a template. We want to use that, basically force standardization across the organization with the query process and audit your own process to see how you're doing, because we can always do better, right? Next slide, please. So what are some of the key initiatives with a query process? So reimbursement methodologies. Compliant queries will ensure we have those diagnoses that are reimbursable, and especially like PDGM, due to the accurate specific diagnosis. So we want to make sure it's as specific as possible. Accurate coding, of course, often facilitates accurate claim submission. And when our claims go straight through, smooth claims mean we've got good cash flow as well. Data. If we standardize what we do, we'll place it in the record and the EMR in the same place so we can retrieve it, and we're better able to track that internally. And then ultimately, there may be data to compare to a national benchmark down the road. The better we perform as an organization, the better we do in value-based purchasing, right? So those better outcomes we talked about earlier become they're a lot of times due to proper diagnosis. They align with those diagnosis functional scores. And as we have accurate information, then we develop care plans that are patient-centered. And again, they produce greater outcomes, which again, greater performance helps us out in value-based purchasing. And then clarifying documentation to make sure we have what is needed for medical necessities is also a function of a good query process. Making sure we don't have tunnel vision when we're looking at our part of the chart, but that we see the whole record as an organization and we make sure it reflects what it needs to. So one example might be face-to-face, making sure that documentation aligns with everything else that we're doing related to that health record. We want to have that consistency all the way through. And if we get things correct up front with proper query, we can reduce the likelihood of audits, denials, takebacks. And if we get these audits, hopefully we fly by with flying colors. Next slide, please. All right, so requirements of a compliant query will include, and Christina is going to get in the weeds here shortly, we want to be clear and concise. The longer the verbiage, the less likely it'll be that it's going to be read in its entirety. When pulling information for a query, reference the quotation where it's from. For example, the provider's interpretation on the x-ray says this. You want to make sure that the provider knows where you're referencing. When we're including applicable indicators from the record, we want to make sure they're pertinent to the query. And if we're offering multiple choice, which is often a recommended way to do this, we want to make sure that it's only relevant options. So unlike taking a test, there's not going to be one answer that's far out there. We're not going to make up a distractor, if you will. We're going to make sure that they're all applicable. There's no number of correct choices we have to have. If you only have 2 choices and an other for them to fill in, that's fine. But we do want to make sure that we do have a spot for the provider to fill in free-form information if they want, whether we call that other, whether it's just a blank spot for them to actually document what they may want to. And never include your impact, as we talked about earlier, on reimbursement, quality, reportable data. To do so would be viewed as trying to lead the provider to a specific answer, which is a big no-no in a compliant query practice. So I am going to hand it over to Christine. Next slide, please, Jan.
Thanks, Sherri. All right, so now we're going to look at when to query. Here's a list of some things we came up with of when to query. So you should query to document clinically evident conditions when they're clearly present but not listed in the provider's documentation. And query if you find conflicting information. For example, if one provider note says one thing and another provider says another thing, that's a reason to clarify. You can also query to clarify the reason for the encounter, especially with when multiple issues are present and it's not clear which one drove the reason for home health. Query when a diagnosis lacks supporting clinical evidence or it seems to conflict with the findings. A query may be helpful to help confirm and correct that. You also may need to confirm diagnoses recorded by non-provider sources like nursing or therapy. If they list out a diagnosis in there and the provider hasn't addressed it directly, you'll want to query to find out if that's a valid diagnosis. If documentation suggests a potential cause and effect relationship, like diabetes and a wound, an ulcer, but it's not stated, we want to be able to clarify. You can query to clarify acuity or specificity, especially to avoid defaulting in those unspecified codes when more detail is supported. You can query to clarify acuity, did that one already. If a diagnosis is listed as a history of, but there are signs it may still be active, that's another time to clarify. Also query when it's unclear if a condition was ruled out or ruled in after testing. Sometimes that initial documentation can be vague and you'll need to clarify. And you can also query to confirm the presence or absence of complications to address diagnoses found in those ancillary notes but haven't been acknowledged by the provider. Next slide. All right, here's some don't query. Just as important as knowing when to query is knowing when not to query. Query should support clarification, not pursue unnecessary detail. So don't query simply because a code would be more specific if the documentation already supports a valid and appropriately specific code. Avoid querying for a very small gap or discrepancy. This can overwhelm providers, create frustration, especially when the issue doesn't impact coding or that patient care. If that record clearly supports a diagnosis and the code assignment aligns with the guidelines, there's no need to query just to tighten it up. We want to focus on the documentation accuracy. So ultimately, queries should have a purpose, clarifying what's unclear, not creating extra work when the documentation is already sufficient. Next slide. All right, guidelines for multiple queries. Well, multiple queries are necessary, especially for complex cases. Maintain clarity and relevance for each one. Each query should stand alone, so be concise, focused, and have it supported by documentation and clinical indicators. You want to avoid bundling multiple unrelated queries together. We don't want to add any confusion, and we want to reduce the chances to get a clear response. We do want to get that clear response. So again, keep each query non-leading and grounded in what's in the record there. Next slide. Guidelines for a compliant query practice. Here, we want to reiterate, use multiple choice responses, but only include options supported by the documentation. You want to keep the language neutral, avoid steering the provider toward a specific diagnosis. Even the title of your query should not reference a specific diagnosis necessarily. It also should not reference reimbursement or quality outcomes as well. And we don't want to introduce any new information. We are clarifying what's already in the record. Remember, a well-written query helps ensure the record is accurate, defensible, and compliant. Next slide. All right, and here are a few other considerations here. You want to have a standardized template-approved process to ensure consistency and compliance across your team. You want to establish clear guidelines for query retention, how long queries and responses are stored, and how to handle unanswered queries. You'll want to define clinical criteria, what clinical criteria are acceptable to support a specific diagnosis. This helps ensure that your queries are well supported and defensible. If possible, limit those queries to one topic per query to avoid confusion, and then also possibly improving response rates from those providers. Ensure your query technology is secure. We always remember, we want to secure that patient's information, also user-friendly, and that it tracks activity. You want to send queries as close to documentation as possible, so timeliness matters there. We don't want to be sending queries from months down the line. We want to be able to get it as close to that documentation as possible. And lastly, if you have an escalation policy in place when clarification isn't received, you want to have that policy in place so that charts don't get stuck. All right, here are our resources.
Thanks so much, Christine, and thanks, Sherri. This was great. I think there's a lot of good information and a nice framework for making sure you're working with queries the best way you can. So let's go ahead and take a look at our poll results and see who is querying in the agencies of the folks that are on the calls today. So it looks like the majority of folks are the clinician is the one doing the querying, and then about half as many, it's the coder. Then we have, you know, a few in each of the other buckets. Sherri and Christine, any thoughts on that? Is this in line with what you're generally seeing?
Yeah, for me, it is in line with what I'm seeing. You know, we sometimes get into the weeds, and some of the terminology in that is very medical. And so in our organization, it is usually referred to, you know, a clinician to actually handle it. And a lot of that just has to do with the verbiage and getting in the weeds of, you know, I've had people that have queried, let's say, from the billing department, and they don't understand, you know, whether or not they got the answer they were looking for. So they're looking for some specific clinical piece, and they don't even know that they got it. It has to go back to the clinician anyway. So we've just kind of cut that out, and the clinician is the one that is usually interfacing with the provider.
That makes sense. Great. All right. Well, thanks again. Now we're going to move on to our scenario spotlight. So let me put that forward. And this is part of the call where we provide a monthly scenario for you to respond to, and then we share the answer in the following month's episode. So this was our scenario for last month, and Christine, you were going to give us a little overview of that scenario and then go over the responses.
Sure. So last month's scenario was about an 83-year-old male patient being recertified for a second episode after suffering a stroke several months ago. The speech therapist knows the patient was able to tolerate slightly thickened liquids and soft foods without any signs of aspiration, but does need occasional cues to avoid taking bites that are too large. In addition, the patient is receiving 4 cans of Jevity daily via his PEG tube to ensure adequate caloric intake. OT documents that the patient is able to feed self with his left hand once food and drink has been set up by the family. And so the question that we had for this scenario was, how would you respond to M1870 and GG0130A? All right, so for 1870, we would want to answer that with a score of 3, and the rationale, able to take in nutrients orally and receive supplemental nutrients through an NG tube or a gastrostomy. So the rationale here is this item looks at both what the patient takes in orally and what the patient may take in via the NG tube, or this case was a PEG tube. Since this patient has both oral and receiving it through his PEG tube, 3 would be the most appropriate response. And for GG0130A, eating, a score of 4, supervision or touching assist would be the correct response. So speech documents the patient is able to tolerate thickened liquids and soft foods without any problems other than cueing on bite size. This would be considered supervision or touching assistance. Remember that this item does not consider any of the PEG tube here that the patient was receiving.
Great, thanks, Christine. And for next month, we have a new scenario, and this is about a patient with severe vascular dementia with agitation. And we are looking for diagnosis coding for this patient, as well as answers for both M1800 and the GG items around eating, bathing, and transferring. So we'll be sharing the responses for this scenario next time. And I'm just going to pause here because we did receive one question from an audience member, and they are wondering, when you get back clarifying information from a provider after querying, do you enter it as an order? What do you do with that information? Sherri or Christine, thoughts?
Well, I think some of that's going to depend on your process, but you could, I guess, if your process was to write an order, have the provider sign it, write it as a verbal order. I think a lot of processes would just include, incorporating a progress note, that you spoke to the physician, including that actual query template into the chart and attaching that to the chart. But it wouldn't be wrong to send off an order, but I think most organizations will probably struggle to have that done. You would just then add that, let's say it's for diagnosis or whatever, to the the plan of care that you're already sending out. Would be my guess, would be how most people would handle that, and then just including that documentation on the health record. Christine, how about you? Any thoughts?
Yeah, I agree, Sherri. I think that the biggest thing here is having that process in place so that your agency is, ultimately has it from each query following that same process. You'll be able to easily identify where that information is. You'll be able to, we say compliant and defendable there. We want to have everything in place consistently.
Great, thanks, Sherri and Christine. All right, now we're moving on to our product spotlight for this episode. And we want to remind our listeners about Decisions to Health's 2025 Home Health Payment and Compliance Virtual Summit, which is happening online September 9th and 10th. Several OC board members and committee members will be speaking as part of this event. And in just 2 afternoons, you'll gain expert insights and actionable strategies to help your agency succeed. The speakers will be covering the latest changes to coding, OASIS, value-based purchasing, medical review, survey preparedness, and more. And you can follow the link in your handouts for more information and to register. And now it's time for What's New with OC, where we share updates from the Association of Home Care Coding and Compliance. And I wanted to let any OC members on today's call know to save the date for our first OC members virtual networking call, which will be on July 30th. We'll be holding a call where you'll be able to have conversations with fellow OC members about the coding and OASIS issues that matter most to you. And if you're not an OC member yet, please join us so that you can join us for this call. And you can follow the link in the handout to join OC, and we will be providing a link to members to register for that networking call in the next issue of the OC e-zine. So be on the lookout for that toward the end of this month. If you're listening to a podcast version of this show, you'll find the handouts on the OC website along with the recording under resources and then free webinars. We hope you enjoyed this episode of OC Talk. Thanks again, Sherri and Christine, for all the great information you shared. And thanks to all of you for tuning in. We hope you'll join us again for our July call when Nanette Minton will be talking about the Hospice Hope Tool. And in the meantime, if you'd like to re-listen to this episode or a previous one on the go, you can find OC Talk on your favorite podcast app. Or you can also listen to the recording and access the handouts on the OC website at oc.decisionhealth.com. And if you have any questions or suggestions for future guests, ideas for topics, or ideas about the format of the show, you can always email me at jan.milliman@decisionhealth.com. Thanks so much for listening, and we'll see you next month. Take care.